Good evening, friends. Myself, Dr. Divyasri. I, I am here to welcome on behalf of Aisha team everyone. We are here today with our 12th webinar series. I welcome all the participants, and today we have a wonderful speaker with us. Thank you for joining.
Hello everyone, I Dr. Jalaj Transne welcomes you All India Homeopathic Student and Youth Association Maharashtra branch. All India Homeopathic Students and Youth Association Aisha is one of the largest association of homeopathic students and youth of our country. This association plays a great role in upliftment of the young homeopaths to take the responsibility on their shoulders. This is the association of the students for the students and by the students. The aim of the association is to work selflessly for the upliftment and ailing humanity. We believe on the phrase, united we stand and divine we fall. So, this is the right time for the young pets across the country to come together and work for the betterment of the nation, to make the India the most powerful nation by devoting the time and work in right direction for the nation. We organize free health camps, free seminars, free webinars, blood donation camps, and we have also developed our own library which we give to the students who are not able to afford books. Aisha family conduct own 9 OPDs at remote village areas. We also promote scientific and research oriented mind of the youth by publishing their articles or presentations or any kind of literature which is value for the homeopathic fraternity and for humanity in our magazine called Homeo Vision. We believe in the importance of time, so our motto is to awake, arise, and work before it's too late because aim says I am always in motion. Our thoughts are our actions, so we believe in having a positive mindset to believe ourselves for rising above the mass for achieving higher purposes of our existence. I will say few words about Samragee Homeopathic Clinic. Homeopathy is based system based on theory of treating like cures, like homeopathy claims to stimulate healing responses to diseases by administering substances that mimic the symptoms and those diseases in healthy people. To provide the treatment, this wonderful system, Dr. Vibha Mevada ma'am, who is a budding and enthusiastic homeopath, had started Samragee Homeopathic Clinic on 4th Feb 2018 at Indore, Madhya Pradesh, India. Dr. Vibha Mevada did BHMS from Nashik University in 2015 and did CCAH certificate course in advanced homeopathy and MCH master course in advanced homeopathy, which are short-term PG courses from the most prestigious institute, the Other Song International Academy and Advanced Homeopathy, Mumbai in 2016. And ma'am is certified yoga instructor scholar by Yoga Certified Board Ministry of Ayush, Government of India. Dr. Vibha Mevada ma'am has been trained under renowned homeopaths like Dr. Rajan Shankaran, Dr. Dinesh Chauhan, Dr. Gorang Gaikwad, and many more, and took many national and international webinars and her articles and cases are published in many prestigious platforms of homeopathy like NJH, hpathy.com, etc. By following the footsteps of father of homeopathy, Dr. Haniman, rare diseases are also being treated at Samragee Homeopathic Clinic. The main intent of Samragee Homeopathic Clinic is to serve people. Several health camps, medical camps, free yoga, and Arabics workshops had been conducted at the clinic as beneficent to the people. There is no denying to the talk that they do not uh, do treat here their best to assure the satisfying results leading to a lifeline to better health. Thank you.
So now it's time to bring on screen the founder of Samragee Homoeopathic Clinic, Dr. Vibha Mevada ma'am. Over to you, Vibha Mevada ma'am, for the speaker's introduction.
Thank you, Orko. Good evening, all of you. As we all know, our today's speaker is Dr. Rakesh Gupta, sir, and sir is going to enlighten us on the topic of homeopathic cure in diseases and related emergencies. So, Rakesh Gupta sir is a MD homeopath in practice of medicine and MBA SCR. Sir is a consulting homeopathic physician and expertise in treating hospitalized patients suffering various acute and acute on chronic diseases with homeopathy for the last 15 years in Mumbai. Sir doing private practice at Juhu Tara Road, Santa Cruz West. Sir is expertise of serving in rural areas of Maharashtra for 8 years and participated in ophthalmological projects for free cataract surgery and eye diseases as medical officer in charge. Sir is expertise in treating ophthalmological cases with homeopathy. Sir is a faculty member and at associated professor and head of department in forensic medicine and toxicology at SMTC MPH Medical College, Vile Parle, Mumbai since last 7 years. Sir got prestigious Sattva Charitable Sanstha. Sir is running this NGO, first NGO to receive the permission for using use of homeopathy as preventive for COVID-19 in Mumbai from NCGM. Sir published many papers in national and international journals, example dengue and homeopathic management, clinical case reports on various emergencies and homeopathic management. Sir is a speaker at various national and international seminars and conferences, speaker at a webinar for prestigious platform like Rotary Club of Mumbai Sion, Homeopathy Preventive or Possible Cure, Geriatric Health with Homeopathy for Rotary Club of Mumbai Hills South, Health Aging for Senior Citizens for Rotary Club at Navi Mumbai, Palm Beach Rotary Club of Navi Mumbai, Sunrise Rotary Club of Navi Mumbai, uh, Rotary Club of D.Y. Patil School of Ayurveda. Sir conducted lectures and seminars at various platforms like PG Homeopathy London course in Mumbai and Medigin Mumbai. Sir facilitated as Corona Warrior by JKT News for utilizing work of reaching 1,20,000 people by providing arsenic album 30 as a preventive homeopathic medicine against COVID-19 and other felicitations and treating COVID-19 cases at COVID centers. So this is in short introduction of our today's speaker, Dr. Rakesh Gupta sir. And what I feel that managing hospitalized cases with homeopathy, in my view, is something which is a great thing. What sir is serving since last many years, and we are very glad to have sir today on our platform. So thank you so much, sir, for giving your time to us, and you're heartily welcome. Thank you.
Now it's time to bring up on screen our today's speaker, Dr. Rakesh Gupta, sir. Good evening, sir.
Yeah, good evening.
Over to you, sir.
Yeah, thank you for a wonderful introduction. So we'll not waste much time. We'll directly start with our presentation. Am I visible? The presentation is visible, right?
Yes, the presentation is visible, sir. Just make sure to click on the hide option beside the stop sharing one.
Okay.
Yes, sir. You are visible clearly and your PPT is also visible clearly. You can continue, sir.
So as you can see, the first slide, you can see the eye is very much similar to the camera. If you can see it very closely, eye is a very important and a vital organ, and it captures whatever is seen in the environment and in the nature. So eye is the most beautiful creation, and treating eye diseases is a very skillful job. So my presentation is homeopathic cure for eye diseases and related emergencies. has always known that eye is the smallest organ of the body, but when it comes to treating the eye diseases, it is very difficult. The reason being, it is very difficult to convince a patient or a common man that homeopathy can help in eye diseases, because a common man or a patient always has a belief that eye condition is always an emergency condition, and it is a do or die situation, because anybody suffering from eye diseases can lose eyesight. So it needs to be treated on urgency basis, and that's why modern medicine becomes a very important option for treating eye diseases. And taking up any eye condition and treating with homeopathy is a very challenging job. So it's a uncommon journey of a common homeopathic doctor. The reason being, there was lack of complete homeopathic model or any kind of homeopathic protocols where we can offer treatment for eye conditions. There was not enough observational experience available in homeopathic world. For this, I will give an example that if you go in any state of India, you'll find there are ophthalmic institutes, eye hospitals where they are trained modern medicine doctors or ophthalmologists are trained to first examine an eye, do a disease diagnosis, and thereafter uh, treat them accordingly. But in homeopathic world, there is no such institute which offers such kind of a training. So it becomes more of a very difficult challenge to know how to treat these cases, and before that, to first and foremost diagnose such cases. So initially there was a lot of discouragement, because in order to learn the clinical diagnosis of ophthalmic conditions, we had to go and assist various eye hospitals where the teaching faculty would be a modern medicine ophthalmologist, where they would find it very strange why a homeopathic doctor wants to know how to treat eye conditions. So, learning ophthalmology was merely a self study, and working at various government and hospitals, attending free medical camps as volunteers, because when there is camp, there are a lot of patients around, and if there are 500 patients, at least we have a possibility of seeing 50 different types of ophthalmic disease conditions. So thereafter, in order to diagnose diseases, we need to have a grip on various diagnostic machines and tools, like learning a slit lamp examination, learning how to do ophthalmoscopy, which is of two types, direct and indirect, then how to operate a keratometer, then how to do a scan. So this all this instrumentation was very important to be learned by assisting various doctors. So these are various tools which can be, which are very useful. So this is a auto refractometer, this is a keratometer, and this is a slit lamp. So this is So it's a 16 years old journey where you evolve as a student, then you become a resident medical officer, then you mature as a medical officer, then you are a consultant, and finally you shape into a senior consultant. So it is like an observational experience. You learn from various observation and you grow into a mature consultant. So I'm just going to share my learning which I have learned over a period of time, so that it is very interactive session, and we can learn from each other. So I would be expressing my gratitude to my parents institute. Like, I did my post graduation from Dr. ML Hospital in the subject of medicine, and I was the medical officer and the consultant in ophthalmology department. Then I learned a lot of ophthalmology from CMPH Medical College at Mumbai Vile Parle and its attached hospital, Shri Mumbai Devi Hospital. I express my gratitude to all my teachers and my senior ophthalmologist doctors. As I have already mentioned, eye is a very small organ. Its affections can be detrimental, and eye can be affected or involved because of various kind of etiology or causes, like there can be an infection in the eye, there can be any kind of inflammation in the eye, there can be injuries to the various eye structures, or it can be a congenital origin disease. Different parts of the eye has a different type of presentation or symptoms which develop. So example, if a patient comes with pain, lacrimation, redness, there is a possibility that it can be either conjunctivitis or it can be a keratitis. The difference between two clinical conditions will be dependent on the presence of photophobia. Keratitis or inflammation of cornea has a very intense photophobia in comparison to conjunctivitis. What I learned over a period of time is more superficial tissue involvement, more are the chances of reversibility, except in the case of if there is a malignancy of the conjunctiva or there is a congenital disorder like coloboma of the conjunctiva. Although conjunctiva is a superficial structure of the eye, but in cases where there is malignancy or coloboma or congenital disorders, then it becomes difficult to treat it. There has been an effort from my end to classify the diseases of the eye, which may help us to approach homeopathically. So the classification is based on the tissue involvement. As we all know, the various tissues of the eye where the disease affection can take place is lids and conjunctiva, which is the most superficial part. Then comes the cornea. Third is the lens and the capsule, sclera, uveal tract. Uveal tract is nothing but it's a continuation of the iris and the ciliary body, choroid, macula, and the retina. So these are the various tissues which can get involved, leading to eye diseases or affections. Another form of classification is according to the causation of the disease, as we have already mentioned, and it has been, we have studied in our homeopathic education also. The cause of the disease is very important. According to Organon of Medicine, the cause of disease is very important. So determining the cause is very important. Here, in context to the eye diseases, the causation of the disease is injury, inflammation, infection, malignancy, or congenital origin, or senile diseases. Senile diseases means diseases which is because of the aging process. They are known as senile diseases. And as we all know, cataract can be a senile process. Or as we all know, when you look at into the eyes of a patient, or old patient, you see a white color ring which develops circumferentially around the cornea, that is known as arcus senilis. That's a part of senile diseases. So when, as a homeopathic physician, when all of us will approach a eye condition, there are few things which should be kept in mind. First is knowing the disease, knowing about the anatomy of the eye is very important, because if you are not aware about the knowledge of the disease, or if you don't know the anatomy of the eye, we may land up in soup, because we may either misdiagnose, or in short, whenever we are treating a patient, it is important to know the prognosis of the case, where we have picked up the case and what can be the outcome of the case if you're treating it well. If the patient is not getting better, what can be the outcome or complication if the patient doesn't respond to our line of treatment. So this is all dependent on the knowledge of the disease and knowledge of the anatomy of the eye. Other thing is knowledge of pathophysiology. I always tell my students that knowledge of pathophysiology is very important. What do you mean by pathophysiology? It means when the disease has been excited, or the disease process starts, and during this disease process, there are various physiological changes or pathological changes which develops, until and unless we reach the final diagnosis. So this journey, right from the onset of the disease till we conclude what is the disease, this full journey is known as a pathophysiological changes. So we need to diagnose the pathophysiological changes, and there are beautiful medicines which can cover in our homeopathic materia medica. We can treat patients when we understand the pathophysiology. Third thing which is very important is knowledge of clinical examination and the diagnostic techniques. When we don't know to diagnose a case, we will not be able to treat the case, because all the patients who are suffering from eye diseases will either come with pain in the eye, redness of the eye, or swelling of the eye, or watering of the eye. So all these are the symptoms which can be in any kind of inflammation of the eye structure. Either it can be conjunctivitis, or it can be because of the inflammation of the cornea, or there can be inflammation of the iris, that is known as iritis. So it is very important for us to diagnose which tissue of the eye is got diseased. This is according to the Boger's concept of disease. Boger has always spoken about the disease tissue, or always spoken about what is the location of the disease or seat of the disease. So that's why we are going to give an integrated presentation where we are going to combine the various homeopathic concept and the modern clinical knowledge of eye diseases and eye structure. So this is what, how do we examine the eye? So basically, very important is, we should not feel that we are not an ophthalmologist. So how can we do a ophthalmic examination? We can approach a patient and try to understand what the patient is complaining about, and do an examination. Because when you are doing a clinical examination, what you get is various clinical symptoms like photophobia, or agglutination of the eyelids, or there is a pain in the one corner of the eye, inner canthi, outer canthi, or congestion in one sector of the eye, or you can get various modalities which helps in prescribing. Mind you all, Boninghosen was one person who had emphasized time and again the role of modalities when we are treating any kind of diseases. So modality is the first thing, whether it is a causative modality or aggravating or ameliorating modality, is the first thing which we need to pick up when we are taking a case. So case taking modality becomes a very important part, and because it helps in prescription. So let us focus on the anatomy. If you see very carefully, so this eye is like a globe. It's a eyeball. It's like a globe, and there is anterior most is the transparent portion of the eye, that is known as cornea. Cornea is said to be the most transparent portion, or the glassy portion. It's like a windscreen of a car, through which the light enters the eye, and then it gets refracted through the lens. So lens is like a glass, the glass which we wear, spectacle glass, or the lens. Once the rays go inside, it will get refracted and it will fall on the retina. So once it falls on the retina, these signals are relayed by the rods and cones which are there in the retina. These are the sensory cells of the retinal layer, and these images are then carried through the nerve which is known as the optic nerve, and then the impression is formed in the brain. So you understand. So any interference any interference in the transportation or the entry of the light from the exterior or the environment into the interior environment of the eye, whether it is the cornea. Suppose there is a damage to the cornea and cornea has become blur, or there is a scarring of the cornea, then the light will get obstructed, and if the light doesn't enter the eye, it will not fall on the lens. Then the patient will not be able to see. That is one of the important cause of blindness. Similarly, if the lens, this white portion is the lens, if this lens becomes opacified, as it is seen in cataract formation, so light will not enter and fall on the retina. So even if the patient's retina is good and there is no entry of the light because of its blockage due to cataract or because of the corneal opacity, patient will not have any vision, because for patient to see, the the light has to go inside the eye and it has to fall on the retinal layer. So hope you are understanding. So when you talk about retina, the most central portion of the retina, this is known as macula. So when you look at me and I look at you, you can see my face and I can see your face. And the area which I am using of the retina is the macula. Macula is one structure of the eye which is responsible for the central vision. So when a patient comes to in the OPD and say that I cannot see your face clearly, I see as if there is a black spot over your face, that is known as scotoma. That means the black discoloration is seen on the central field. That is maybe because of the macular diseases, provided provided the lens is normal. If there is a cataract, central nuclear sclerosis of the lens, then also you will see there is a black spot in the center of the vision. So we have to rule out whether the lens is completely transparent or it is opaque. Then only we can go and label that the patient has got macular diseases. Okay, so these are few things which I am trying to discuss, so that we are aware about it when we are discussing cases. So this is another this I have spoken about cornea, I spoke about the lens, I spoke about the retina. Okay, I spoke about the optic nerve, I spoke about the macula. Okay, so there is an anterior chamber of the eye. The anterior chamber of the eye is formed with the cornea and the iris. So this is the entire anterior chamber of the eye. Okay, this is the entire anterior chamber of the eye. So when you say anterior chamber of the eye, what happens is it has got filled with aqueous humor. Aqueous humor is nothing but it is a sterile fluid which is secreted by the ciliary body. This is the ciliary body. It secretes and it gets accumulated into the anterior chamber. Now the reason for uh, this aqueous humor collection is cornea, as you have already mentioned, that cornea is the most transparent portion. So if it is transparent portion, that means there is no blood vessels in the cornea. So that means it needs nutrition from some other source. So aqueous humor provides nutrition to the cornea by nourishing it through it endothelium of the cornea. Okay, so and the other source of blood supply is at the periphery of the cornea. So this is the periphery of the cornea, where that is known as corneoscleral junction. So this is the corneoscleral junction where we get blood supplies, and through this it nourishes the cornea. And since this is a corneoscleral junction, from this point onwards there is sclera. Sclera forms the outermost coat of the eyeball. The white portion which you see is the sclera. Okay, that is known as the sclera. So here I have spoken about the anterior chamber, aqueous humor. I spoke about the sclera, corneoscleral junction. Cornea is transparent. Cornea doesn't have its own blood supply. It receives its nutrition from the aqueous humor and from the corneoscleral blood vessels. So eye is like a globe. Globe is composed of the membrane. There's one other important thing which needs to be remembered is sclera. There is another portion. This is known as the iris. Iris is like a shutter, camera shutter. When you look into my eyes, if you see the black color, you see your eyes are brown, someone's eyes is black, someone's eyes is blue, someone's eyes is of a different color, gray color. So the color which changes is not because of the any other thing. It is mainly because of the iris. So this is the shutter of the camera. So moment I look at the bright light source, when I look at a bright light source, my iris will contract and it will narrow down. So when it contracts, the centralmost portion, this portion is known as pupil. So then you feel some people have got a very narrow pupil. Some people have got a dilated pupil. It's mainly because of the adjustment of the shutter, camera shutter, or it's known as a human camera, that is iris contracts. Okay. So when you talk about the structures of the cornea, the anterior part of the membrane is transparent, as I've already mentioned. Cornea is like a watch glass, which is like being inverted and overlapped by the sclera in the periphery. So important tip, when you understand the layers of the cornea, very important thing is the outermost layer of the cornea is epithelium. Then second layer is Bowman's layer. Third layer is the stroma, and the last layer is the Descemet's membrane, and the lowermost is the endothelium. So why am I describing this is stroma, this layer of the eye is responsible for the transparency of the cornea. Okay. If any injury extends to this layer, the patient will develop corneal opacity. Okay. So we have to assess while a patient of injury comes to us, we have to be very careful whether the injury is at the superficial layers or it is gone beyond that, that is known as the stroma. Okay. So I have already mentioned that cornea doesn't have a vascular supply. I have already mentioned that it gets its nutrition from the endothelium and the sclerocorneal junction. Okay. So this is the example of the corneal opacity. If you can see it, this is an example of the corneal opacity. This is the corneal opacity. If this corneal opacity, if by chance this white color discoloration injury is over this area, cornea, so what will happen is it will cover the pupillary area of the eye, and if it covers the pupillary area of the eye, so imagine how the light will enter. It will get blocked, light will not enter. So this will become one of the important cause of blindness. So whenever I take sessions on ophthalmic diseases, I always get a question that can we cure blindness. So before I address to this question, I always say we should know what is the cause of blindness, where is the disease location, what is the actual cause. You understand? So that is what I would like to convey in this lecture also. We need to ascertain what is the seat of the disease. So what happens is whenever there is an injury, there is, as we know, we have read pathology, various stage of inflammation. So there is injury. Okay. Every injury is followed by inflammatory changes, and inflammation always has a post-inflammatory adherent scarring. So there is a scar formation which develops, and this scar formation leads to opacification because of the fibrin tissue deposition, and that leads to permanent damage. So this is what we need to, that's why it is very important that we preserve our eyes properly when we are traveling or whenever we are playing any sports or whenever we are, doing any kind of activities related to firework, or whether we are actually, having a construction work going on or carpentry work going on or a plumbing work going on, because any small piece of particle entering the eyes and it damage the cornea can lead to serious injury or permanent injury. So here comes the concept of reversibility versus irreversibility. So whether the case of injury or whether the case of inflammation which has come to you, which is related to cornea, whether it is a reversible zone or it is a irreversible zone. So this is very important. So again, I tell my students, and it is one of the take-home messages, is that whether the disease is actually reversible phenomena or irreversible phenomena. So what is important is to classify the disease, what kind of disease you are treating, because it will obviously help us, or it will reflect on the concept of potency selection. So all this we have already covered. Other important thing is the central retinal artery and vein. Another important thing is the outer muscles of the eyeball. Whenever we look right, whenever we look left, there is always a conjugative eye movement. If I have to look right, my both the eyeballs will move. If I have to look left, I have my both the eyeballs. This is known as conjugate eyeball movements. So this is response. This is very important, and it is mainly because of the extraocular muscles of the eye, which will help the movement of the eyeballs. So let us come to symptomatology. So we need to differentiate, uh, uh, conjunctivitis from iritis and glaucoma for various therapeutic approaches. So there a patient will come with red eye. So there will be redness in conjunctivitis as well as iritis and glaucoma. In conjunctivitis, the congestion is superficial. Iritis, it will be little deeper, vessels will get inflamed. Glaucoma also, the deeper vessels will get inflamed. Usually in conjunctivitis, the discharge is mucopurulent, whereas iritis it will be watery, and glaucoma also it will be watery. Then you have to look at the pupils of the eye. The pupil in conjunctiva is normal reacting to light. That means when you put the light, it will constrict. When you remove it, it will dilate. And in iritis, it will be small and irregular. And in glaucoma, it will be large and oval. So this is very important. When you see the media means what when you are doing a torchlight examination, you see the cornea, you see the anterior chamber, and you see the anterior surface of the lens. That is known as the media. Media is clear in conjunctivitis, whereas in iritis you find there is opacities, small opacities or pigments which can be seen in the pupillary area. In glaucoma, the cornea will become hazy because glaucoma is nothing but it is the increase in the intraocular pressure of the eyes which leads to edema of the cornea. In intraocular tension, in the intraocular pressure will be normal in conjunctivitis. Iritis, it will be normal, whereas in glaucoma, it will be very high. Similarly, when we talk about pain, pain is very mild in conjunctivitis. Iritis and glaucoma, it is very, very severe. Okay. When you talk about the clinical examination, when you touch the eye that and check for tenderness, in conjunctivitis, there is no tenderness. Whereas in iritis, there will be some amount of tenderness, but glaucoma patient will have severe tenderness. Vision, eyesight, conjunctivitis patient, their vision is very good. They will not complain of reduced vision. So this is very important. Decreased vision or dimness of vision is not a symptom in conjunctivitis. Whereas in iritis, patient may say there is reduction in the vision. In glaucoma, the vision will be very less because of the very serious intraocular pressure increase. The vision will drop down. Onset in conjunctivitis is very gradual. In iritis, it is also gradual, but in glaucoma, it is a very sudden onset. Sudden onset eye pain with redness. The alarming thing is glaucoma, and other symptoms like headache is present in iritis and in glaucoma. Glaucoma patient may complain of severe headache and vomiting, along with severe eye pain, and patient will be very drained and exhausted. So these are few symptoms which we need to know. So let us start with one of a very important case which I had treated, a case of a dacryocystitis with abscess and the orbital cellulitis. So what do you mean by dacryocystitis? Dacryocystitis is nothing but it's an inflammation which leads to suppuration and of the lacrimal sac. So when we talk about lacrimal sac, so there is a lacrimal gland which is always present on the lateral aspect. Lateral aspect, here is the lacrimal gland of the eyes. From here, the tears are generated. It goes into the eyes. Okay. And whenever we blink our eyes, that is a time where the cornea becomes is lubricated, because blinking is a very important thing. If you blink the eyes, this is a time where the tear film is formed. In a patient who has got paralysis, hemiplegia, or facial paralysis, especially Bell's palsy or something like that, if eyelids are not closing properly, okay, so they cannot close their eyelids properly. So in those cases, if the eyelids are not closing, the tear films are not formed, and the patient may complain of dry eye. So once the tear films are formed, it covers the entire cornea and the sclera, and whatever excess is there, it goes and gets drained from the punctum, which is their upper punctum and lower punctum of the lacrimal duct, and then it goes and combines in the main nasolacrimal duct, and then it goes and get drained into the uh, nasopharynx. It gets drained into there, into the nose. So this is how this system works. So when there is any kind of an obstruction in this system, so then the organisms they proliferate and the infection can take place, which is known as dacryocystitis. So hope you understand what is the meaning of dacryocystitis. So there are dacryocystitis of two types. Either there is a chronic dacryocystitis or there can be an acute dacryocystitis. So the main reason is lacrimal blockage or the punctum getting blocked, as I have already explained. There is a stasis of the tear in the lacrimal sac, and the contents get infected because there is organisms, and infection leads to suppuration and inflammation. So this is what happens. The reason for blockage can be either there is any kind of stricture or scarring due to infection, or there is any pressure from outside, or there is you know a hypertrophic turbinates which presses on the this nasolacrimal duct opening. So this is how the system is. If you can visualize it clearly, this is how the tear flows from the superior and the inferior punctum, and there is a lacrimal sac. This is a nasolacrimal duct, and this is how it drains into the nose. So any obstruction at this level or this level or this level or this, the tear films will get obstructed, tear flow will get obstructed, and it will remain here, where there can be possibility of infection in this canal and the nasolacrimal duct. Then the pus may form. So this is what. So this is how the disease develops. There can be swelling, then there can be an abscess formation. So now let us uh, go how to manage in such situation. So when we talk about treatment, we have to always know what our modern medicine doctors have to offer. So what they do is, usually if patient doesn't settle down, they will start with oral antibiotics, then they will go on the intravenous antibiotics. And if this is not manageable, what they will do is they will do a surgery which is known as dacrocystorhinostomy. So they will open up the entire system, and they will again create a bypass where the tears can flow into the nasal cavity. So in homeopathy, what we have to do, we have to select a proper simillimum, which will be based on the symptom which the patient is presenting, followed by the necessary constitutional remedy if it is coming up. So this is a case of a 40 years old lady which had presented with swelling and redness over the left eye since last 5 days. So it was an acute onset. There was a periorbital swelling. Periorbital means anything around the orbit is known as periorbital. There is a periorbital swelling involving the left eye, eyelids over the medial aspect. So this is how the patient has presented. This is a real photograph of the patient. If you see, there is a swelling here. If you can see within this red circle, you see this swelling. So imagine the swelling which is even not allowing the patient to open the eyes. So symptom was pain which is radiating to the left side of the head, pricking sensation. The modalities which patient presented is better by ice application or cold application, better by cold air and draft of air, and eating any kind of sour or sweet food, it is aggravating. Patient was complaining of irritability because of this pain. Patient was very irritable by nature, and all these things had started to current situation. Current problem started 5 days back, and previously also 2 years back she had complaints of itching around the eyelids, which was better after taking homeopathic medicines. Physical symptoms, physical what we've got is there was a thirst for cold water, and patient was a hot patient. On observation, it was seen that the patient was covering the eyes with dupatta and want someone with her and cannot stay alone. On finding, on general examination and local examination, it was found that patient had tenderness and swelling and the redness of the left eye, and there was a punctum or the pus which was clearly seen, and the eye was having sticky watery discharge, and the eyelids were stuck together. The patient was not able to open the eyelids. The totality of the symptom is, what we found is swelling and redness of the eye, which was a pricking sensation, is better by cold application, better by draft of air, and the pain radiating to the left side of the head, and irritability with pain and the hot patient. So if you see very clearly, we have given more importance to the modalities according to the Boninghosen's concept of totality construction, and then followed by the disposition of the patient and the thermals. So if you see the repertorization, we find that the general symptom of the patient, where the mental general aggravation was there, that desires company and alone being aggravation was seen in the patient. Then what we saw is the orbital cellulitis as the symptom which was taken up. Pain stitching was taken up because it was a very important sensation, and cold application amelioration was taken up. And if you see the remedies which are coming up is Apis, Rustox, Argentum nitricum, Hippasulf, Silica, Arsenic. These were the various remedies which were coming up. As we understand the thermals of the patient was a hot patient, and if we rule out thermals, what we see is that the Rustox, Argentum nitricum, Hippa, Silica, Arsenic, all these drugs are eliminated, because if you take it as an eliminating rubric, it gets eliminated, and the remedy which comes up is Apis mellifica. So we selected Apis mellifica, and it was selected in 200 potency because patient was quite sensitive. So we took it in a moderate potency, where we did a dilution technique, was the technique which was used because patient was in distress. Now here, what is important is, if a patient is developing an orbital cellulitis along with the pus formation in the orbit, so the chances of this infection spreading to the cranial cavity is very high. So here we have very less time. We need to eliminate the pus and settle down the inflammation and the cellulitis. So that's why frequent repetition was advisable. So we started with first dilution every 5 minutes. So imagine first dilution every 5 minutes was given. So dilution was created by diluting the 15-20 pills in 1 glass of water, and mixing it thoroughly, and 3 tablespoons was given every 5 minutes. So you see, when we were giving it very repeatedly, within less than 24 hours, patient's abscess bursted. The pus came out from the pus came out. You can see this pus is coming out from the swelling. All the pus was drained. Patient was now able to open the eyes. So before the pus, patient was not able to, because of the pus and the swelling and cellulitis, and the patient was not able to open the eye. Now, as soon as the pus was drained, and that was not any mechanical intervention, it was only after giving homeopathic medicine, patient's pus was drained automatically, and the patient was able to open the eye. On the third day after medicine, you can see the swelling is completely, the pus pocket has completely disappeared. The swelling is also less. So after 3 days of medicine, cellulitis had resolved, redness had decreased, and patient was able to open the left eye completely. You can see it. After 10 days of medicine, now gradually you'll ask whether the medicine was continued every 5 minutes till 10 days. No, as the patient's pulse was automatically drained, the 5 minutes repetition was changed to half an hour, 45 minutes, 1 hour. See what technique I use in treating acute cases and hospital admitted patient is giving frequent repetition as and when the patient's susceptibility is restored and the patient's symptoms are disappearing. The repetition is reduced gradually from 5 minutes, 15 minutes, half an hour, 1 hour, 2 hours, 3 hours, 4 hours, gradually. After 10 days, you can see the photograph. It is much better. You can see patient has this area. If you can see carefully, the entire swelling is settled down, and just a small opening which is seen. After 20 days. Now, if you see it very carefully, after 20 days, nobody will be able to tell that whether she had a decreased cystitis. You can see her left eye. So this is a case which actually help us to know how a homeopathic medicine, if selected carefully and integrating it with the knowledge of the disease and knowing what can go wrong or knowing what is the prognosis of the case. If the medicine is helping, then also you should know what is the prognosis, and if the medicine is not helping, then also you should know what is the prognosis or what are the various complications which can develop. So here in this case we have learned concept of the disease. Then we learned about concept of taking history in an acute. We also learned about the concept of constructing totality based on the Boninghosen and Bogus concept. Then repertorization, and what is important is concept of selecting the right potency and posology in order to get optimum result, especially if it is an emergency. See, in chronic cases, everyone has time. You give a dose, patient is better, then also it is fine. If you give a dose, patient is not better, then also it is fine, because we know it's a chronic disease. Patient will come back. We have a second chance to change the remedy, change the potency, increase the repetition, or reduce the repetition. But in acute, we don't have time. It's a very snapshot prescription. You have to be very accurate, and we have to be on our toes, because if the medicine doesn't help, we have to be ready with our second plan of action, that is known as Plan B. So this case is a very a good example where how a homeopathic medicine can replace an antibiotic, how a homeopathic medicine can replace a need for doing a surgery. So this is a very important take-home message. Now we talk about the second. So we have covered the nasolacrimal duct, the case which was related to nasolacrimal duct. Now we go on a case of a 19-year-old male who is complaining of recurrent itching, redness, foreign body sensation, and photophobia. Now be careful about the symptomatology. The previous case, there was pain, swelling, patient was not able to open the eye. Here patient is complaining of redness, itching is there, itching, pruritus, and foreign body sensation is there, and patient is developing photophobia, light sensitivity in both the eyes. Now, very important thing is the symmetricity of the complaints. So usually eye diseases, if it is symmetrical, then what should click to your mind is either it is an allergic phenomena or it is an autoimmune phenomena, because usually symmetricity is not seen very commonly. Okay, usually one eye get involved. You patient will say, I cannot see in one eye, there is a cataract in one eye, or there is an injury in one eye, or there is conjunctivitis to start with in one eye. But here patient is complaining of both the eyes or symmetrical complaint. And other important is itching. Itching and symmetricity should give us an alertness that patient has an allergic phenomena. If you understand it's an allergic phenomena, then automatically we'll be able to understand the seat of the disease. Okay, where is the disease location? So now patient said that there is a itching, redness, foreign body sensation, and photophobia, which is better by cold water washing and cold application. And it gets aggravated at night, and it is aggravated either in the morning and aggravated in the evening. So there is no very specific time modality, but it is more aggravation is seen in morning and the evening. So again, if you understand, morning and evening is a time where the environment is little cold, and this is a time where the allergens are also quite active because of the coldness, because coldness, the pollens and the other allergic components are very high. Okay, because there is a trapping of the dust or the trapping of this allergic material in the lower atmosphere. Because of the coldness, there is condensation. So if you see, this is the real photograph of the patient who is complaining of an allergy. Okay, who's complaining of the allergy. So that's why clinical examination is very important. This is another take home message for all our viewers, that clinical examination, had I not everted, this is known as eversion of the lid. You have to evert the lid, look at the lid and evert it. Eversion of the lid will lead to the clinical. If you can see it, it is very easy to evert the lids. I have everted my lid. So when you evert a lid, you see the undersurface of the lid. This is known as the palpable conjunctiva. Palpable conjunctiva, and you see these are like small pebbles which are there on the conjunctiva. So imagine if these pebbles are there on the eye, imagine what kind of distress. Normally the conjunctiva is completely plain, you can see my conjunctiva, it is plain, there is no pebbles, you can see it, there is no pebbles. Okay, it is smooth surface because it is covered with the conjunctival layer. So patient has developed this pebbles kind of a thing, you can see it. So these are causing the foreign body, or the sand like sensation, or as if there is stone in the eyes. So these are known as papillae, which are seen on the palpable conjunctiva. Okay, so what we find is huge papillae, and the tissue involvement is the conjunctiva. So this is a classical case of allergic vernal keratoconjunctivitis. Vernal means it's an allergic phenomena. Kerato means it is also involving the cornea. As I had already mentioned earlier, if you find photophobia as a symptom, it means the corneal involvement has started, and patient is having initially to begin with conjunctivitis, and now the cornea has also got involved. So, vernal keratoconjunctivitis, it's a form of allergic eye disease which specifically affects young adults or young boys, where there is itching, redness, photophobia, and lacrimation. Clinically, you see it as a giant papillae. You see it as a giant papillae. It was looking like a stone, cobblestones. Normally, the conjunctiva, inner surface of the conjunctiva is smooth. Here, you are seeing as if, small. So, this examination was done on the slit on the slit lamp examination, and it was also done on the, you can see it on the naked eye or the torchlight examination. So imagine, the examination is very important. If you would not examine and take a symptom and you prescribe a remedy, then you will not get a optimum result, or you will not be able to do a therapeutic planning and programming of the treatment protocol. We need to have a planning and programming of the protocol. So there was giant papillae, hyperemia, and there was a superficial keratitis. So superficial keratitis was noticed by when you're doing a slit line examination. You find there are small spots or dots seen on the cornea. That means there is inflammation of the cornea which has started. Imagine, I have time and again I have said, cornea is a transparent structure. It has to be transparent for the light to enter. If there is inflammation of the cornea, it will become hazy and there will be dots, and because of which you will see light sensitivity. You will not be able to see clearly. So the remedy which we selected based on the conjunctiva as a tissue with cold amelioration, and evening and morning aggravation which was seen, primarily evening aggravation. We started with pulsatilla 200 to begin with, and then we followed with 1M potency as a phasic remedy, and then we, over a period of time when the patient's phasic symptoms had settled down, we followed it with a constitutional remedy, which was a nacromure in this case. You see on the left hand side, you're seeing that we are doing a torchlight examination and finding there are papillae, huge papillae in the inner surface of the conjunctiva. You can see it. But when after treatment, even after doing a microscopic examination, you can't find any papillae. So imagine by homeopathic treatment, this patient has completely eradicated with these papillae, which was causing the foreign body sensation in the eye, and patient was having difficulty in opening the eyes and light sensitivity, and patient was completely better after we give this regime of pulsatilla 200 followed by 1M. Once the 200 action was exhausted, we shifted on the 1M potency. So this is what we saw as a result. So this is known as the slit lamp examination. You have to make the patient sit on the and rest the on the chin on that particular stand, and then you do an examination, and you see that various structure of the eye can be examined by this. So up till now, in this case, what we learned is identifying the cause of disease is very important. When you give a homeopathic remedy and you understand that this patient is suffering from an allergic phenomena, so you give a homeopathic remedy which is itself helpful to treat the disease phenomena. But if the patient is continuing to get exposed to allergic dust, or going and getting exposed repeatedly, this phenomena has to be treated with the preventive measures. The patient has to be advised that you have to use proper glares or goggles while he's out, while he's traveling or driving. Another important thing is we have to keep the patient on the constitutional remedy so that his hypersensitive reaction, a type 1 hypersensitive reaction, which is an allergic phenomena, is taken into consideration, or it has been modified by giving homeopathic appropriate indicated and constitutional remedy. So these are the two cases which we shared. One was related to a nasolacrimal duct system, other was related to the conjunctiva. Now we move on to the third case. Hope you all are understanding. I think we'll get some on the chat box on the YouTube. Imagine this is a case of Usher syndrome. Usher syndrome, where a young boy who comes with the complaints of reduced but intellectually is keen. Is a case. This is a case of 22 years old. 22 years old male who had presented with complaints of both eyes, the retinal layers getting involved since he was 10 to 12 years of age, and it has gradually progressed. Uh, right eye is more affected than left eye. There is a dimness of vision, loss of vision, and there is night blindness. There is a night blindness, and initially it was a night blindness. Gradually, it was a reduction of the vision in the daytime also. There, if you can see, this is what happens because of the night. In cases of Usher syndrome, this is what happens, where a person will start seeing the central portion of the person whom he is looking at, whereas the periphery will become completely black. So this is known as tunnel vision. Tunnel vision is the vision which develops in patient who is suffering from retinitis pigmentosa, which is a part of Usher syndrome. So the patient on fundus examination was diagnosed to have retinitis pigmentosa since he was 10 to 12 years of age. His vision was deteriorating gradually. Along with this, in Usher syndrome, he doesn't have only retinitis pigmentosa. He will also have loss of balance. He had deafness. He had deafness because there is involvement of the cochlea of the inner ear and the organ of corti, and he was mute. All his milestones were delayed, motor milestones. He could not prone, he could not sit, he could not walk. Everything was delayed. So this is the entire picture of the patient who is 22 years, right from his childhood, right from his birth. He has delayed milestone. He was mute since his birth. He didn't develop his hearing capabilities. He had imbalance, and then adding fuel to the fire, patient developed dimness of the vision, night blindness, loss of vision, and now he had difficulty of vision during the daytime also. So, what is Usher syndrome? Let us understand Usher syndrome. It's an autosomal recessive disorder where there is mutation in any of the 10 genes, and it leads to deafness and blindness. And deafness is associated with gradual loss of vision. Deafness is because the inner ears, they are not developing, and in the eye, especially the retinal layers of the eye gets involved, and it leads to retinitis pigmentosa, which is a degeneration of the retinal cells, and predominantly the rod cells of the retinas are affected, and patient usually complains of initially the night blindness. Night blindness is very important. Patient coming with night blindness, first diagnosis should be retinitis pigmentosa, and retinitis pigmentosa can be of various reasons. One of the reasons is Usher syndrome, and gradually there is loss of the peripheral vision, so that the patient will develop a tunnel vision. The patient will say as if I am seeing through a tunnel. So exactly opposite is seen in the macular disorder, where patient will only have the tunnel vision. Macular patient will say patient will have peripheral vision, not the central vision in macula, whereas in retinitis pigmentosa patient will have a tunnel vision, whereas the peripheral vision will be lost. Similarly, in glaucoma, there is restriction in the peripheral vision. Okay, so glaucoma and retinitis pigmentosa both have exactly the same presentation, whereas in macular disorder, you see the periphery, but you cannot see the center. You can't see my face, or I cannot see your face if I'm suffering from macular disorder. So this is what you see in normal vision is you see everything. Normal vision is you see everything. You see everything, normal vision. Okay, in retinitis pigmentosa, especially in our patient who is suffering from Usher syndrome and developed retinitis pigmentosa, peripheral vision cannot be seen, only the tunnel vision or the central vision is seen. Peripheral vision is diminished. So this is what you see on retinal examination. This is the fundus photograph. Uh, you see a bony spicule shaped pigments which are seen. Bony shaped spicule pigments which are seen. You can see this. These are bony spicule pigments which you are seeing are deposited in the peripheral areas. That's why a patient can see only the central. The peripheral retina is getting damaged, so you can see only the central part. That's known as uh, uh, the tunnel vision, because there is a peripheral retinal atrophy which is developing, and the macula is preserved. So this is the central portion of the eye. This is the macula. Macula is normal. That's why you can see the central vision. Other thing which we found during case taking, patient had delayed wound healing with suppuration, and sweating was partial sweating on the scalp, and he had craving for meat and sweets. Sweet was more than the meat. What we understood during the case taking, when we were talking to the patient and the patient's relative, what we found is, in spite of his illness, patient has an ability to adapt to his environment. He could cope up with these studies. Although he was a special person or a disabled, he would go to a special school and he could cope up with the studies. But amongst other children, he was more inquisitive and very creative. He had his own creativity, which was preserved in spite of all these problems, delayed milestone, and his special senses were not working, vision and the hearing had not developed. He could not speak. He could score well and stood first in the school. So this proves about his intellectual ability. That's why I have given title as Usher syndrome, where the patient is physically incapable, or a special person, or a disabled, but intellectually is very very well to do. Intellectually is very 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 keen. Then when we took the repertorial totality, what we found, he has anger contradiction, he has a travel desire, he desires company. Physically, he was weak, but intellectually, he was strong. He was very creative and fastidious. Dreams of falling and dreams of religious dreams were there, and craving for sweets and sun aggravation was there. Then, other important physical general which was seen in the case was delayed wound healing and night blindness. So, remedies which emerged up after totality or the repertorization was natriumure, lycopodium, calcarea phos, carcinosin, and phosphorus. So it was seen that patient was physically a little weak or deficient, but intellectually was keen. While we were differentiating the various remedies, on the other hand, physically the rubrics like craving for sweets or meat or sun aggravation, it was seen that Lyco and natrum was coming up more close. When we were looking through a pathological rubric like inflammation of the retina pigmentary, which was seen in the synthesis repertory, lycopodium was the only three mark drug which was seen. So there we shifted from natriumide towards lycopodium. Then there is a loss of vision, especially at night. Lycopodium was the marked remedy in this rubric when we were going through the repertory. When we were taking reference from Norton's Eye Therapeutic, which is it's only one therapeutic book which is there for eye diseases. So imagine, it is a very old book, but it is the only one eye therapeutic book which is available in the market, and that also it is out of print. So when you were going through that book, it was seen that lycopodium was a very important remedy which was covering retinitis pigmentosa. So this is how we evolve from the patient. You do a clinical examination, you come to a conclusion. From the conclusion, knowing the disease, knowing the concept of the disease and anatomy and pathology, thereafter you take a totality which we come to know as a, so because this helps to select between what is characteristic and which is less common or more common. What was striking in this case is, in spite of all the weaknesses, in spite of all the God's wish or God's gifted disabilities, this person was intellectually very sharp, which was very alarming, and that is a hallmark of lycopodium. And when we took a reference for various therapeutic book and the various pathological rubrics in the repertory, lycopodium was listed in those rubrics too. So overall, lycopodium was covering the patient both at the level of mind as well as the body, and don't forget about pathology. So there was a trio and combination of mind, body, and the pathology. This is what we want, and this is the ideal match which we are trying to select anytime and every time we give a remedy. So miasm, when we are listening to the miasm, or sorry, when we are going through the miasm, what we found is a syphilitic miasm because it's a genetic disorder. Susceptibility is low. Congenital disease secondary to consanguineous marriage. So here the history of consanguineous marriage was also tracked down. There was a family within the relation. There was a marriage, and advanced irreversible structural pathology. It's an advanced irreversible structural pathology. That's why classification of disease is very important. So it's a chronic miasmatic disease with fully developed symptoms, with pathological symptoms, and it is structurally irreversible. Only few characteristic symptoms at the level of disease presentation was seen, and the disease had only the common symptoms of the disease. Whereas when you track down the personality, you found the various constitutional symptoms. So here, what we thought is we should select lycopodium as a remedy, and since the patient was intellectually also very very sharp and very creative and very sensitive, we thought of going on a higher potency, but we didn't want to, since it's a retinal cells and we didn't want any kind of aggravation, so we selected safely a 50 millisiemens potency because of the structure irreversibility and also keeping in mind the frequent repetition of the dosage, because it is important to arrest the progress of the disease first and thereafter going on the phase 2 of the cure. Okay, so cure, we don't know how much we'll be able to achieve, but at least we should arrest the progress of the disease and try to restore his vision. So potency selection should be, what I thought according to my understanding, is 50 millisiemen. So I started with lycopodium 0 by 1 3p HS. So when we are doing treating such case, therapeutic planning is very important. So it is all dependent on the disease knowledge, and we should know what is the objective of the treatment. As we know, it's a congenital genetic structural irreversible disorder. The first thing is to stop the progress of the disease. Second is to restore the functioning of the diseased tissue. That means the patient should be able to at least see something, to target the structurally diseased tissue in order to restore the anatomical changes as far as possible. It is, in this case, it is next to impossible to revert to a normal tissue like us or a normal retina, but we are trying to restore as much as possible. So it needs a medical line of treatment, intercurrent force, where we can use is syphilinum. The remedy which we are selecting is lycopodium 0 by 1. Surgical intervention may be required if there is a underlying cataract which develops. It is seen that Usher syndrome patients may also develop cataract. So if a cataract is developing, we may require a cataract surgery later on, but primarily now we are focusing on the retina. So what we saw is, we started the treatment in Feb 2011, where during the start of the treatment, what we saw is patient had in the examination left eye, there was only hand movements can be seen. Patient could not read anything, and without specs in right eye he could see 636. But once the specs was given, left eye you can't see anything, but right eye he could read up to 618. So this was what was seen at the start. Then we started with lycopodium. In after a week, there was an improvement in the balance. Okay, headache had reduced, vision had improved, but we continued the medicine because it takes time for us to see some change in the clinical examination. So we continued lycopodium, and eventually we continued it for for 2 months. Lycopodium was continued gradually from 3p. We shifted to 7 powder, 7 packets per week. And overall, at the end of 2 months, what we found is loss of balance. Loss of balance had improved. Loss of balance was better, absent. Then headache was completely disappeared. Vision was better, but deafness and mutism was there. What we found is, when we did examination, now the same examination we are doing, okay, the eye examination, visual examination was done. The patient who could not see with a specs in the left eye, he did not have any vision. Plus with a specs in right eye, he had 6 by 18 vision. The same patient started seeing with a spectacle in the right eye, his vision from 618 to improve to 66, imagine. And in the left eye, where he could just see a hand movement, and even when you're giving a spectacle, patient could not see anything in the left eye, the vision improved to 6.9. So it's a very, very good achievement in especially cases which is congenital, which is involving the sensory nervous tissue of the eye, which is a retina, and the patient is now able to see. So it's again, this case reflects upon the concept of knowing the pathology, knowing what tissue you're treating, understanding the various presentation of the disease, and then applying a constitutional remedy in this case, which is covering pathology as well as the structure of an individual mind and the physical generals of the patient. And other important thing which we learned from this case is identifying, since we are using a very deep force, which is a constitutional force, and the diseased tissue is a very sensitive tissue. Irreversible change is there. Selecting a remedy with a 50 millisiemen so that we can repeat it frequently if required without any chance of aggravation. So this is what we have achieved, which is a very good achievement by giving homeopathy, because patient has already gone to a lot of ophthalmic doctors, and he's right now 22 years, and he had gone to various doctors for last 10 years. And so imagine, where in comparison to 10 years, 2 months of homeopathic treatment, and this is what you achieve, is very important. So this case reflects the role of homeopathy in a congenital and a structurally irreversible disease. So now, up till now, take-home messages: role of clinical examination, role of knowing the eye disease symptomatology, examining the patient with the eye disease and identifying which tissue is getting involved, and proper history taking, focusing on the modalities and the causative modalities of the case. Then remedy differentiation, picking up the remedy in the right potency and posology, and planning and programming the case is very important. Planning and programming what is to be done next is very important. I hope you all are understanding, and there are a couple of more cases uh, going on. So there is some another. I mean, in the chat box, when I'm seeing, there is some suggestion or the questions asked that for how long the APIS was continued in the first case. So APIS was, see, when we are treating any pathological case, now you understand there is inflammation, and inflammation has resulted into a disease product formation, that is an abscess. So imagine, if there is an abscess, there is inflammation, there is a gap which forms, all the tissues gets necrosed and all the debris gets liquefied. So there is a lot of tissue damage around, if you understand. So the remedy should not be prematurely stopped. Here we come into an impression that if we give more repeatedly, the patient may get aggravated. Yes, patient may get aggravated. It all depends on the case which you are treating. If you are treating a case which has got a pathological angle, and if you are using, according to the aphorism number 246 and 247 in the sixth edition of the Organon of Medicine, Dr. Hahnemann has clearly indicated that if you can select a remedy, and depending on the pace of the disease, you have to understand the pace of the disease. In today's world, if there is 2020 format, you have to play like 2020. If you give a single dose and wait for the patient to get all right, where the case demands repetition, patient will end up leaving you and going to an ophthalmologist or going to a modern medicine doctor and taking treatment. Because see, imagine, in a span of a week, if a patient's eye is completely, better, it's nothing like it. So APIS was continued frequent repetition. I have already mentioned that APIS repetition was reduced as the disease phenomena started regressing, as the disease was coming towards normalcy. The repetition from initially 5 minutes was made 3 hourly, 4 hourly, then it was TDS, QDS. So we are practicing weaning technique. Why don't we learn from modern medicine doctors, where they are giving steroid therapy, or they are giving, today's COVID world, they are giving a lot of drugs. They themselves, they practice on the weaning technique. So I am using the same technique, using homeopathic remedy, and I'm weaning off the drug, where patient is happy, patient's disease is resolving, and we are gradually reducing the repetition. This is what we do in pathological cases. Another case, yeah, there is another question which has been asked. Why don't you show some squint cases? So this is one case which I was treating. It was a neuropathy with extraocular muscle palsy. So when you say squinting, it means the one muscle of the eyeball is weak. That's why the eyeball gets deviated in some other direction. Okay, so the person will not be able to maintain the gaze of the eye. That's known as squint, or strabismus in our language. It is known as. So this is a 21 years old lady, She's a known case of autoarthritis. Autoarthritis is an autoimmune disease. Autoarthritis means the inflammation of the aorta and the arteries with renal arterial stenosis. So imagine she has got an autoimmune phenomena. Why am I telling you this? Is to understand the depth of the pathology, the inflammation, which is it's an autoimmune phenomena which is involving the important structures like renal artery. So when you look at her eyes, eyes is a very beautiful structure of the human body. You have to look at the eyes, but when you look at the eyes, you understand what is the abnormality. So let us see what is the abnormality. If you see this right eye of the patient, she is able to look inwards, but left eye is stationary. Left eye patient is not moving, it is fixed. So there is no one in this world who can move only one eye without moving the other eye, until unless one eye is paralyzed. So this lady is suffering from paralysis of the left eye, and this is known as a form of squinting. Okay, and she also had scabies. So one hand there is an autoimmune disease of autoarthritis, other hand there is extraocular muscle paralysis of the left eye, and third she has scabies. So she had left lateral rectus palsy. So while doing clinical examination, we know this dictum LR6 SO4 rest 3. So LR means lateral rectus is supplied by the sixth nerve, which is an abducent nerve. SO4, okay, SO4, and then it is important to know is uh, uh, the rest other muscles are supplied with the oculomotor, which is the third nerve. Okay, so left lateral rectus palsy was there. There was a pain, and it has developed after crying, and there was a lot of emotional issues in her life, and especially her main problem was that she was quite insecure, and she had that fear that she will lose her loved one, she will lose her boyfriend. That was what she had, that fear. And on the skin there were macular eruptions which were better by cold. So she had developed that scabies which I had shown you on the on the hand. This is a photograph of the hand. This is scabitic lesions. These are scabitic burrows, scabies burrows. So this was what we got it in physical journal was craving for sour, aversion meat. Patient was better by cold water. In general, patient was better by cold water, and similarly, patient was better by cold water, especially as far as the skin disease is concerned. Was getting aggravated in the sun, especially the skin. She used to develop arterial rashes when she was exposed to the sun. Life situation, if you understand her life situation, she is very bubbly, very vivacious. She has a very, very childlike behavior, very joyful, playful, and very talkative, very expressive, sociable, communicative, yet sensitive, both physically and emotionally. Pain tolerance was also less, and emotionally is very sensitive, as seen by she had that imaginary fear. She will be left alone by her boyfriend. That feeling was there. Emotionally is very weak. She would require some kind of emotional support, cries very easily. That was seen. Insecurity, fear of losing the loved ones, and clairvoyance. Clairvoyance was there. She had those clairvoyance. She could seeing things which would happen few days later on. That was there. Past history of typhoid. So what we understand miasmatically, I understood in this particular case that patient belongs to a tubercular miasm, both in the at the level of mind as well as at the level of the body. She is very hypersensitive as well as hyperreactive, and similarly at the level of the disease, patient is having autoimmune phenomena and inflammatory changes which is seen, and she had a past history of infection. So I thought that probably she belongs to a tubercular miasm and shifting towards syphilitic. So patient was suffering from scabies and left abducent nerve palsy. That was the diagnosis. The remedy which we thought in this case selecting was phosphorus 200. We started with 3 packets per week and followed by daily dose depending on her response to the medicines. So what we saw in this case, after a week, her diplopia. So what happens is if one eye is moving and another eye is fixed, usually we develop diplopia. We see double vision. Okay, so that diplopia was better. Movement in the eyeballs had improved, and patient sleep had improved because the itching also had reduced. Itching patient was not able to sleep, and other journals were also normal. So if you see in this photograph, over a period of 2 months, when she was on this treatment, we found. Now you'll say it took 2 months for it to recover. Here we have to understand that patient is suffering from an autoimmune phenomena. So the reason for her to develop this neuropathy was an autoimmune inflammatory response. So usually in this case, when the patient is on autoimmune diseases and they develop any neuropathies, the neuropathies are often treated by giving heavy dosage of steroids, and these doses of steroids can last for 3 to 4 weeks, and then usually patient steroid is tapered off, and the response is seen overall over a period of a month, 1.5 month, 2 months. So in, we have replaced the need for steroids and giving a heavy dose of steroids, corticosteroids, by giving merely homeopathic remedy, and that also phosphorus, which was her covering her mind as well as her the physical symptoms of the body. If you read the physical symptoms, especially if you open up bogus synoptic key and you understand the tissue covered by the phosphorus, it has rightly mentioned that nerves and inflammation, both the things have been mentioned, where the nerves are getting inflamed, and at the same time the patient can develop the various pathologies of the eyes, like squint, diplopia, and others. So if you see the first photograph where the left eye is fixed, the patient is just not able to move the left eye, but the right eye is can be turned inwards. The person is able to turn the eyeball inwards. And now in the second photograph, you can see this is the conjugate eye movement, which is very important. So this conjugated eye movement is what is the normal phenomena. No human being can move just one eye and keep the other eyeball fixed. That's why we are always checking during ophthalmic examination or neurological examination. Especially, we always check for the conjugative eye movements, especially when you are examining oculomotor nerve or abducent nerve, okay, and other nerves of the eyes like trigeminal nerve, okay. So this is what we need to say. And now at the end, after going through this case, what we have learned is again the disease concept and identifying what is the cause of the disease is very important. Clinical examination is definitely important. If you know your disease confidently, if you know what is the disease pathology, your prognosis of the case can also be understood very well, and your ability to convince the relative, your ability to tell the relative or the patient that okay, because it is very difficult. Someone is not able, eye is gone completely haywire, eyeball has gone completely haywire. Patient is already a case of aortoarthritis. Patient is already a renal artery stenosis case, and this case is patient is developing in another disease. Third important organ is getting involved. So imagine how difficult it is for patient to rely on homeopathy. So it is your confidence, or it is our confidence as a homeopathic doctor to convince the patient by expressing that this is a disease phenomena, this is the line of treatment which a modern medicine doctor provides, and this is my line of action, this is my therapeutic approach which I am going to do, and don't worry, I'll be able to treat you. So this is what we have to convey to the patient and patient's relative. So this thing cannot be just conveyed, it comes by experience and seeing a lot of patients. So I mean, when we were seeing eye OPD, I used to see at least 300 patients a week, 300 patients a week. And so imagine if you're seeing 300 patients a week, so your ability to diagnose various eye conditions, your ability to use the therapeutic measures, or your ability to use the diagnostic techniques will also improve. And as far as we say, the disease affects as a whole, similarly the medicine has to treat as a whole. So if you see her hand, a lesion started fading off, the skin also improved gradually. So here we have to also focus on law of Herring's direction of cure. It should not happen that skin is improving and eye is not improving. That is also important. So here in totality, you have to be clinically good. Diagnostic technique has to be good. Your therapeutic planning has to be good. Material referencing has to be good. Your follow-up assessment is also important. That is also important, and that is what I am trying to show you in this particular slide. So there are many more cases which can continue. There are more than 250 slides. So do you want me to continue?
Yeah, sir, you can, sir.
Yeah. So I think that this is the last case which I will share with you, which is again a very interesting case. It's a case of ophthalmic emergency. So up till now we have covered nasolacrimal apparatus and infection. Then we spoke about the conjunctiva, that also vernal keratoconjunctivitis. So I forgot one thing about vernal keratoconjunctivitis. The same picture can be seen in patients who are wearing carelessly contact lenses. If you wear a lot of contact lenses and you're not careful about the hygienic measure of the contact lenses, or you're just wearing contact lenses and going to sleep, then you may develop such vernal keratoconjunctivitis. Okay, then we spoke about Usher syndrome, which is a very important pathology. Then the fourth case which we spoke about was neuropathy, a paralysis case. So we are covering, if you can carefully observe, we are covering each tissue after tissue. So that's why I selected those cases which covers each pathology. This is an ophthalmic emergency which knocks our door. It's a case of corneal laceration with hypopyon, with iritis, with posterior synechiae, with pupillary capture, with complicated cataract. So it's a very complicated diagnosis. In short, I'll tell you, there is an injury to the cornea. Cornea में injury होने के बाद there was a pus formation in the anterior chamber. There was a pus in the anterior chamber which I had described. Then there was iritis, inflammation of the iris, which I was saying that's like a shutter of the camera. Then because the shutter of the camera became inflamed and it was very, very soft, it went and got stuck onto the lens which is posterior. Okay, which is known as pupillary capture, and there is a cataract formation. This is how the patient presented. So all the patients are live patient, and these are all the actual photographs of the patient. So patient presented with acute congested swollen watering eye with visual loss. So imagine if this come to our clinic, we are half scared. What we will be able to do in such cases, So that's why I say eye looks very small, but eye affections are very dangerous. So it was a case of a 45 years old fisherman who reported to the casualty with history of injury. While he was fishing, the iron wire cut the cornea 13 days back, and the left eye was swollen, lacrimation, swelling, pain, and visual loss because of mere injury. So imagine injury to the cornea is now gone into blindness. So this is one of the important cause of blindness, where the entire vision is lost. There's difficulty in opening the eyes, especially in light. I have already given you a take-home message. More the photophobia, higher the chances of the cornea and the iris getting involved. So we have done the differentiation in the previous slides, in the earlier slide. So there was a pain in the left eye, stitching pain which was worse by light, worse by cold air, and better by warmth. So here again, so whatever case you are treating, don't forget the basic principles of homeopathic history taking. Always try to find out the various modalities, because modalities will help us to reach the remedy. So this was an acute congested eye, lid edema. There was a lot of lacrimation. Patient is not able to open the eye. Photophobia, light भी डालेंगे तो patient was very restless. Then what we did is PRPL. So when you get an eye which is not even, patient is not able to open, what you do a PR means projection of rays. What you do is you take a torchlight, you take a torchlight, okay, and you tell the patient from where the light is coming. Can you see the light? First you ask whether you can see the torchlight. The patient will say cover the normal eye and say whether you can see the light, and you ask from which direction. If you find patient is able to perceive the light, that means there is some life in the retina. Because now right now, because there is swelling, there is injury to the cornea, there is a pus in the anterior chamber, obviously you will not be able to do a fundoscopy and see what is the state of the retina. So you do, this is an indirect method of knowing the viability or the life of the retina. So you do PR and PL whether it is present or not. Luckily in our patient it was present. What you see here is, this is a naked or macroscopic eye examination, naked eye examination. What you see in this particular thing is, you see this is a pupil of the eye. It is opaque. Pupillary area is white. Then what you see is this shadow at the base of the cornea. You see this is a pus in the anterior chamber. So, and then in this, these are different angles, and this is all slit lamp photography which has been done by me by keeping a camera on while doing a slit lamp examination. If you can see this, this is the laceration which is at 8 o'clock position. This is a clock, okay. This is 12 o'clock. This is 6 o'clock. This is 7 o'clock, and this is 8 o'clock, okay. 8 o'clock position, the patient has laceration, okay. And if you see very carefully, here you see the pupillary area. This lens has become completely opacified, and the iris is also become irregular. Normally the iris is beautifully circumferential. Here the iris has become very irregular, and you can see brown spots. These spots are because the iris become inflamed, over inflamed, and it has become fragile, and it has got stuck onto the lens. And when it is stuck to the lens, it has broken. It is broken and it is lost. It is shed off its pigment onto the lens. See, now here you can see the pigments onto the lens. Can you see this? These are pigments, brown color pigments. This is again some part of iris which has got stuck. This is some other part of iris which has got stuck. And you can see this. This is nothing but this is a pus in the anterior chamber, which is known as hypopyon. Irregular pupil, you can see irregular pupil. You can see posterior synechiae. Posterior synechiae is nothing but iris has got stuck onto the lens, which is there on the posterior aspect. That's why the word posterior is used. Synechiae means adhesions. The iris has become muddy iris. You can see muddy iris, like a mud. Iris is normal. It's not so blur, or it is not so, it's a muddy iris. And another important sequelae of the disease is there is a cataract which has developed because of the intense infection and inflammation of the eyes. So there is opacification of the lens. So imagine now the light cannot enter the eye, and it cannot go on and can get refracted on the retina. So how will a person see? That's a blindness. So anybody who asks whether you can treat blindness, you should say, okay, it depends on the disease which the patient is presenting with. So this is one of the best photograph which I could click. So imagine this beautifully, you can see the iris which has got stuck. It looks 3D. This photo is like a 3D photo. You can imagine this. The iris has got stuck onto the lens. Yeah. So iris is stuck to the lens, and that's known as posterior synec. You can see that iris is going, behind and it getting stuck. So on examination, the role of clinical examination while treating patient on homeopathy is circumcorneal congestion is seen, photophobia, intense photophobia, corneal laceration at 8 o'clock, hypopyon, and pupils are not reacting to light, posterior synec, iris pigments, and complicated cataract. So when you go to our source books like Clark's Materia Medica, or when you go to Allen's Encyclopedia or Herring's Guiding Symptom, you often find a lot of pathological, or Borik's Materia Medica. There are a lot of pathological terminologies which are mentioned in the chapter of eye. So this is what we have to see in the clinical practice. So here I have already covered knowledge of the anatomy, and you all know it. We spoke about cornea. Cornea is a clear protective layer of the eye. We have already done it. It should be clear so that light enters. Curvature of the cornea is, mind you, very important. If the curvature of the cornea is haywire, obviously again the light will not refract in a correct direction and you won't be able to see. So here there was an injury to the cornea, which is the protecting layer of the eye. Disruption of the barrier. What you found is the infection. When you break the barrier, the organism enters into the anterior chamber and there is a pus formation in the anterior chamber. Patient had already visited an ophthalmologist and was not improving because he was prescribed some oral line of treatment, that is Odoxil, which is an antibiotic. Vicelon was given. Local topical eye ointment, Zoxan ointment was given. Uh, um, um, Milk flox eye drops was given. That is nothing but it's a moxifloxacin eye drops. Steroid eye drops, Predmet was given for 13 days, and still the patient was not improving because patient had developed infection and inflammation. So here if you see, before we start tackling this case, we need to know what is the state of the retina. The way the injury has happened to the cornea, there is a possibility that the injury can be on the retina also. And if there is injury to the retina, there is a possibility that the patient may develop, excuse me, may develop retinal detachment, because retina is the most sensitive layer of the eye. So imagine you may be coming across a patient or a neighbor or someone who is playing cricket and suddenly one ball hits the eyeball and patient stops seeing it, or patients feel as if the curtain is floating in front of the eye. So that is nothing but it's a retinal detachment. That is what patient, if moment you get such patient with such a history, immediately patient has to be transferred for to the ophthalmic institute, because he may require fixation of that detachment by injecting certain drugs which goes and presses the retina back in the position. So that's a surgical emergency. So before knowing what is the state of the retina, we should not take up this case, because what happens, we may just say, "Arey, we will treat the patient," but if the retina is only detached, however amount of infection and inflammation you treat, patient will not be able to see. So what you do is you do a sonography, which is known as B scan of the retina of the left eye. What we did is, there was no evidence of any detachment. There is no evidence of any hemorrhage in the posterior chamber. That is, the vitreous hemorrhage was not seen. And we did a intraocular pressure examination by a method known as tonometry. There is an instrument known as tonometer, which is used to examine the intraocular pressure. The right eye was 13.6 and the left eye was 14.6. Anywhere below 15 is not troublesome. Anywhere it crosses 15, 16, then that means the intraocular pressure of the eye is increasing. So we have already discussed about the diagnosis. Now what a modern medicine doctor will do, if the oral medicines fail in modern medicine, what they do in such cases is they would inject antibiotic below the conjunctiva, or that is known as some conjunctival instillation of the antibiotics. Other thing what they do is they do a paracentesis. Paracentesis is a process where you inject at the corneoscleral junction and you irrigate the anterior chamber, or you clean up the anterior chamber and remove the pus from the anterior chamber. That is known as anterior chamber wash. And And the last thing which they do give atropine so that the pupils dilate. That means the iris will more stretch more so that it will not get stuck onto the lens. More it gets stuck onto the lens, and more the pigments are there on the. So that means the glass is becoming more dirty and dirty. The lens will not be able to take the normal light inside and refract normally onto the retinal layer. So this is the line of treatment which a modern medicine doctor will give. And what a homeopathic doctor like you and me can do, we have to understand first before treating. So post-traumatic suppuration of an eye and inflammation leading to complication like iritis and cataract with visual impairment. So here it is very simple for us. I don't know anything. I know only the pathology, and I will pick up the cause, which is a trauma. So, and I'll classify accordingly. So according to me, this is an acute, local, surgical, non-miasmatic disease which has developed because of injury with secondary dynamic miasmatic expressions which are fully developed. And this is according to aphorism number 186. So it is, to begin with, it's a surgical disease, but the body has responded in form of inflammation and suppuration and leading to a miasmatic evolution with fully developed expression. Why is it important to know this classification? Because we will exactly know what kind of treatment we have to give. So it is a structurally irreversible disease prima facie, because there are a lot of structural changes which has taken place. Before we start the treatment, we have to understand that if the hypopion or the pus in the anterior chamber keeps on increasing, it will block the anterior angle of the anterior chamber, which will lead to a glaucoma, because the angle of the anterior chamber is the place through which the aqueous humor drains continuously, and it is replaced by the new aqueous humor. If it gets blocked because of the pus, what will happen is the aqueous humor will not drain, and it will get accumulated into the anterior chamber. The new aqueous humor will come and the old will not get drained, and the pressure in the eye will increase. This is one thing which we need to know. Another thing which we need to know is the infection may spread to the posterior chamber. If you don't treat it properly, the infection, the pus and the all may go into the posterior chamber, and it may involve the entire layers of the eye, which is known as panophthalmitis. So that is what I was trying to say. If this angle gets blocked, this angle, then the pressure will increase, and it will increase on the entire eyeball. Raised intraocular pressure will compress the optic nerve, and if the optic nerve is compressed, the patient will develop optic atrophy. So you have to know all in which direction the case can go. You should know all the direction. So optic atrophy, if you do a examination of the fundus, what you see is this is the optic disc, and this is the central portion which is known as the optic cup. Normally the disc and the cup ratio is 0.2 to 0.3. That means if the disc is 100%, only the 20% of the disc is covered by the optic cup. If this cup is increasing in size, and it is increasing in size to 0.7, 0.8, 0.9, means 90% of the disc is covered by this optic cup. So this is an indication that patient is developing optic atrophy because of the intraocular pressure. So normally the disc is this, and this is the cup, which is hardly 0.2, 0.3. This is a normal cup is to and the disc ratio. So strategy of the treatment is, what we have to do is, there is a medical line of treatment which is homeopathic medical line of treatment. Corneal injury with infection and the pus in the anterior chamber and the inflammation has to be taken care. And first is to treat the infection and the pus, and second is to reduce the inflammatory signs and control the iritis, and completely quieten the eyes, quieten the eye. Treat the infection as well as the inflammation. That is the only way in which we can treat the patient. And the step two would be the surgical line of treatment, where we complete the first step and we will shift the patient on the second step, which is a surgical line of treatment where we remove the cataract, which is the end result of the disease process or the sequelae of the inflammation. So imagine if the cataract is such a hard cataract and you try to treat the patient with homeopathic line of treatment in this particular case, the response is going to take months and years, and the patient will not be able to see till then. So what we have to see, we have to understand the scope of our line of treatment, treat the infection and inflammation, quieten the eye. Quieten the eye means disappear all the traces of infection and inflammation from the eye, and go to step two, which is a surgical line of treatment where you remove the hard cataract and replace it with the replace it with the artificial lens, so that the patient is able to see the can restore the normal vision immediately. So here the cause, homeopathic line of treatment, if we understand cause is injury and the effect is suppuration. Modifying factor is the injury, and modifying factors would be the various modalities. So where we make the acute totality, eye injuries from, then inflammation of the iris, okay, iritis with hypopyon formation, eye pain where the patient was aggravated by cold, patient is better by warm application, and type of pain stitching. So the remedies which are coming up in the repertory sheet is Hipasal, silica, thuja, spigelia, aconite, sulfur, nitric acid. So fisherman, so this is one part. Then the second part is, let us consider his background history and the constitutional history. What we found is the fisherman is non-interfering and a silent guy, will not retaliate even when people are trying to fight with him. In such situation, wife has to intervene, but there is no fear, but he doesn't like fighting with people around. He is a workaholic and an industrious individual. He continues to work even with his traumatic eye. He is mild by nature. He is industrious. And if you refer Ken's Materia Medica Industry Mania for Work, page number 319, he's a chili patient. He has got heel cracks, disease pathology as you have seen, Monignoson's concept of totality formation, if you can see properly, we have taken modalities into consideration. So there is, in the photograph, we have seen injury and what is the effect of injury. So initially, I feel this patient belongs to a tubercular myasm because of the heightened sora, that is known as tubercular myasm, because of the inflammatory process and the inflammation which has resulted into the infection. Okay, so injury which has traveled till suppuration, that's why I consider it as the tubercular myasm. So there were two things, constitutional drug which was coming up as silica, and the acute remedy, other remedies when we did the repertorization, the remedies which were coming up was Hipasal, silica, sulfur and spigelia, and here constitutional is silica. Now we have two paths. One is whether we continue with silica, pick up silica and start with silica as a constitutional remedy, or we go on other drugs like Hipasal, sulfur or spigelia. So for this, we need to do a remedy differentiation, focusing on the pathology evolution. We differentiate the drugs. When we were going through a differentiation, we should also understand what is a philosophical concept on which we are treating. We should know that disease is a dynamic phenomena, and it starts from the phase of normalcy, and then it goes into a diathesis, and then it goes into the disease. And disease always evolves from the prodrome to functional to the structural. So when we say prodrome, maybe trivial symptoms. And when we say functional, there is an inflammatory. And when we say structural, in our case, it is pus and the cataract formation. So what is important is the concept of pathogenesis, which is very important. There is a cause, disease effect, evolving effect, and the changing phenomena. It's a ever-changing phenomena. Okay. So here injury, inflammation, and mind you, there is suppuration. That's not pure inflammation, but there is inflammatory suppuration. So the remedies which we think need to differentiate more closely is HEPA, sulf, and silica, uh, referring various source books. Here the ailments from injuries covered in HEPA as well as silica. Injuries which leads to suppuration is there in HEPA as well as silica. Pathogenesis are different in both the remedies, as we will understand. HEPA sulf is very quick and sudden suppuration and very hypersensitive. Silica, the suppurations are very dormant, torpid, and slow. There is impending suppuration or there is incomplete suppuration. Many a times it is written in the source books that there is incomplete abscesses or induration which responds to few dosages of silica and then the person heals. Whereas in HEPA there is rapidity, quickness, and violence. In silica, there is very slowness, delayed, stubbornness, torpidity, which is seen, and incomplete separation. At the level of mind, we often see the patient is very hasty, violent, irritable, and dissatisfied, and they are very, very aggressive individuals, whereas silica are very tolerant and endurant. So, touch me not and hypersensitiveness is what is a hallmark of HEPA self. So, this is what is the differentiation. Further, when we go, uh, cornea is the seat of disease in HEPA self, whereas silica also has got cornea as a seat of disease. In HEPA, it is known for a lot of ulcerations, whereas silica is known for fibrosis, psychiatric formations, and opacification. Both have got common modalities. Cold aggravation is there in both, and warm amelioration is there in both. So what is the difference here is HEPA has more of ulceration here and cornea has more of cicatrices and opacification. When we talk about the cornea and the anterior chamber, when we go into the disease picture of HEPA self and silica, we have found that HEPA self has got corneal and anterior chamber tissue involvement. Mind you, I was always talking about tissue involvement. Silica has more affinity for lacrimal duct, nasolacrimal duct, inner canthus, and patient may develop more of dacryocystitis and lacrimal fistulae. So everything is going in congruence. The only thing difference lies in the tissue differentiation, tissue involvement. So when I understand from miasmatic angle also, HEPA self generally originates in a tubercular miasm and it progresses to the syphilitic dimension. Silica originates from the psychotic miasm, as rightly seen from induration, slowness, torpidity, incomplete abscesses, and later it may go into tubercular dimension. So miasmatic study can be done through the disease expression and the phenomena and the pathogenesis which we are seeing in the patient who is suffering right from its origin till the end. In our case, there was an injury and then the cascade of inflammation and infection which landed up into a complication. So this references are very important when you are understanding the disease phenomena. So this is the difference between HEPA self and silica. I am feeling that HEPA self has got more of location as a seat of disease as cornea and anterior chamber and the suppuration and all is common in both HEPA as well as silica. Whereas when you talk about spigelia as a drug, it has affinity for the nerves. So orbital neuralgias is more common in spigelia and they have more of autoimmune inflammation and inflammation rather than the suppuration. So patient will have very sudden manifestation. Patient will develop iritis rather than developing any kind of infection which is leading to suppuration, or they may develop neuralgias of the eyes where patient will not be able to touch the eye, and the patient will have uveitis or patient will develop retinitis. All these pathologies are more without any kind of pus formation. Okay, this is what is spigelia. Whereas in sulfur, as it covers more of psoriatic dimension, it has more of pruritus, more of itching, more of allergic phenomena, more of lid pathologies, more of a hair hair loss from the eyelids, more of blepharitis, means itching of the hairline eyelids, okay, or conjunctivitis. The sensation, burning sensation, is very important in, and patient is definitely better by cold in sulfur, which we have seen in eye sector. So now the option is between Ipaz and the silica. What I feel, uh, both are going very close, but seat of disease is more covered with Ipaz. I go with Ipaz. But before understanding Ipaz and silica, we should understand what they have a relation. There is a relation between Ipaz and silica, and that's a complementary relation. Complementary action is related to right timing of the administration of the remedy. So when you talk about complementary relation, the timing is important. If you give a right remedy at wrong time, the patient may not improve. But the same remedy, if it is given at the right time, patient will improve. Okay, and if you give a right remedy in wrong time, it will act as a nullifying effect or an antidote or ineffective effect is seen. So this is what is written about the complementary remedies. So in our case, Hepar and silica both are complementary. But if we do not understand the exactly which remedy has to be given at this point of time, patient may not improve, and we may prove ineffective. So what we did is acute remedies. Hepar was selected. We covered the causation. Miasmatically, we understood as the tubercular miasm, covering the suppuration. As the disease had developed within 10 days, and in a week duration, patient developed pus and all the defenses was broken, and suppurative phenomena was very predominant. So that reflects the rapid progress of the pace of the disease and the cornea as a seat of disease. So what I did is we started with Hepar in initially 200 potency, then 1 m, and it was given repeatedly every 4 hourly, and the treatment was almost, this regime was followed almost for 1.5 months, and the follow-ups over a period of time, the follow-up was taken every 2 days, 3 days, but I am giving you overall gist of the entire treatment of what we had done. So at the end, the follow-up, pain, swelling, lacrimation, redness, pus, photophobia disappeared gradually over a period of 1.5 months. Cataract and posterior synechiae were there because they were the sequelae of the infection and inflammation, which needs a surgical correction. What is more important is hypopyon disappeared. So you can see in this photograph, the hypopyon is completely gone, disappeared, and here the iris is looking little normal in color rather than looking very muddy and very inflamed, and even the inflammation part is settled. Eye is completely settled. These are all vascularization which has developed because of the iris getting stuck there, but there is no active inflammation and infection in the eye. So this is how the eye looks. This is how the eye looks. This was what was seen initially, and this was after the treatment. Patient was able to open the eye. Edema had settled from the upper and the lower eyelid. The congestion had settled. Okay, and the patient was completely. All the signs were of inflammation and infection had subsided. So then this acute phase was over. Now it was taken over by the chronic phase, or the chronic constitutional remedy, which we had already finalized as silica. Okay, so acute remedies are selected on the basis of acute presenting totality. Acute remedies are superficial acting. They match the suddenness, violence, tempo, and the intensity of the disease effect but it cannot have a sustained effect for a longer period. That's why we need to give a chronic constitutional remedy, which are deep acting drugs, and sustained effects are seen both at the functional and the structural level, because once the acute phase is over, follow it with a constitutional remedy so that the patient doesn't have any kind, even if there is a minutest traces of any kind of infection, inflammation, that will also get eradicated. So they represent a logical representation of the action to the chronic phase and leads to conclusion of the case. Conclusion of the case. So the constitutional remedy silica, since it's a constitutional, we selected lower potency, 30 potency, It was started from the June 2010, and it was continued for 2 months, and it was weekly one dose for 5 weeks. Why is it important to give weekly dose and eradicate whatever is the minutest traces of infection and inflammation? Because now we have to move on to the step 2, which is a surgical line of treatment. Mind you, if there is any trace of infection or inflammation in the eye, and such a case is taken up for surgical treatment, then the patient may develop inflammation of all the layers of the eye, and the patient may go into panophthalmitis, which will lead to shrinking or the shrinking of the eyeball, and that is known as phthisis bulbi. Patient will turn permanently blind. Forget about blindness, the eyeball will only disappear. So that is what is. So in this particular case, we had gone very thoughtfully. We treated it very methodically, and to your surprise and my surprise, we did not give any kind of antibiotics pre-operatively to this patient. We had treated this patient primarily on homeopathic medicines, followed it with acute as well as constitutional drug, and we had quietened the eye. When I say quietened the eye, we had treated all the infection and inflammation both, and then we had taken the patient for surgical almost after a period of, you can you can say, after a period of almost 3.5 months. The patient was subject to the surgical line of treatment to remove the cataract and restore the vision. Patient eye was quiet after homeopathic line of treatment, which eventually made ground for surgical intervention. Ophthalmologist decided to operate for left eye cataract extraction with PCIOL insertion. So this is how the cataract was removed, and it was replaced by a normal lens, artificial lens. Okay, this is a lens which can be seen, and there was a wide iridectomy done. Whatever the lens was stuck, the iris was stuck onto the lens was cut and removed, and then the lens was extracted and the new lens was put. So this is how the patient was at the end of the entire process. So this case demonstrates the concept of knowing the anatomy, concept of knowing the disease phenomena, concept of materia medica differentiation, selecting the right remedy at the right time, complementary remedy, understanding the entire protocol, understanding the scope and the strength of homeopathy, and understanding where is the limitation of the homeopathy, understanding what can go wrong or the prognosis of the case. You know, so this case is definitely a case which is real a bomb emergency, and it needs a alertness, and you will not believe, I have photographed not less than 3,000-4,000 photographs. Every 2 days, 3 days, we were keeping an eye on this patient because we didn't want any complication. Neither the complication of infection going on to the posterior chamber, neither we wanted him to develop into a glaucoma. So imagine primarily taking over with homeopathy and replacing all the modern medicine drugs. It's a big challenge because when such patient is there, there is IV antibiotic, there is IV steroids also is given if the oral medicines are not acting, and then pupillary dilatations are done, and then you go into the anterior chamber and you do a irrigation of the anterior chamber and remove the pus. So what not is to be done in such cases if the primary oral antibiotics and oral therapy fails, and all this thing is replaced by simple homeopathic medicine, which is based on the principles of medicine, ophthalmology, and materia medica knowledge, and integration with the organon and philosophy. So here, I think we should end the session because we have covered up the majority of the tissues of the eye. And at the end, after the cataract extraction, the patient vision was 6/6, and there was no signs of infection and inflammation. Okay, so here I think we'll address the questions if there are any questions.
Yes, sir. Few questions are here.
Yeah.
Uh, Can we have hope in the color blindness cases?
Yes, color blindness can be tackled with homeopathic line of treatment, because basically we have to target on rods and cones, so proper history taking, and having remedies which has got effect on retinal layer has to be chosen. Majority of the time phosphorus as a drug comes up in such cases. So we have to see whether phosphorus is matching the diseased tissue as well as the constitutional of the remedy. Other polycrest remedies also come up, like lycopodium comes up, and many times we have to use intercurrents like tuberculinum and syphilinum in such cases. But color blindness, what is more important is understanding the occupation of the person, and giving them certain ophthalmic aids, because while they are working they should not have any kind of disturbance, because when you are treating it homeopathically, we require our medicines, we need to give them some time to bring the effect. So maybe it is not that you give medicine and next day patient starts seeing. It is over a period of 1 month, 2 months. Until then we require assistance. So the concept of ancillary and auxiliary line of treatment is very important. You don't just make a patient sit at home and then I'm treating for color blindness. You give some ophthalmic aids which are available nowadays. We give them, and at the same time we also give homeopathic line of treatment and review the patient every 1 week, 10 days. We can get results in color blindness also. Any other question, please?
Yeah, thank you, sir. Another question is here. Can we cure nystagmus after pontine infection?
Contact.
Can we cure nystagmus after pontine infection? The question is on your screen, sir.
Pontine infarction. Pontine infarction, yes. So pontine infarctions are basically, you have to now understand the disease pathology. If the infarction is there in the pontine area, that means the patient may be having comorbidities like diabetes and hypertension. So then we have to target the remedies which are covering diabetes, hypertension, and atherosclerotic changes. Definitely, we can, if we are giving the right remedy and the patient is developing the infarction can be restored. But the physiotherapy means ocular eye movement exercises are also important in such cases. So there is a chance, but it depends on the area of infarction. The major areas, the reversibility chances also reduces. So you cannot just guarantee. Maybe 10-15% cases they respond, and they come out. So it is all depend on the selection of the remedy on the disease which the patient has developed. The infarction is definitely means there is some amount of ischemic thromboischemic phenomena or thromboembolic phenomena which has taken place. So then the remedies which develop comes up is like a group of remedies like Crotalis, or the group of remedies like Bothrops, or the remedies like Arnica, Nux vomica. All these remedies they come up. So we can give them those remedies and see how is the response.
Yeah. Okay, sir. Thank you. The another one is, could you please share us rubrics? I don't understood actually on which case about Dr. Anudeep is asking for the rubrics. Sir Anudeep sir, if you put the question again, we can request sir to show that.
So, sir, maybe as far as I've understood, he's talking about nystagmus and the rubrics. So, any direct nystagmus rubric is also given, or auxiliary movement of the eyeball, or rapid movement of the eyeball. There are various rubrics which are given in the a chapter of eye in the synthesis repertory and Kent's repertory. So these are the rubrics which can be selected. So what is important is, I'm time and again addressing, is chasing the symptom is important, but chasing the symptom is partly important. Which what is more important is why the symptom has originated, why this pain in the eye is there, why the nystagmus is developed. So as rightly said, understanding the pathophysiology and pathology or the disease cause is important. And if you understand the disease cause, the concept can be formulated, and the we can customize the treatment plan. The way we customize our clothes, or the way we customize our spectacles. Similarly, the treatment plans needs to be customized depending on what are the disease expression. We cannot just say that this is a remedy which will help, like Hipar and silica, both are remedy for hypopyon. But when we customize depending on the case taking, then we come to a conclusion, okay, that Hipar was suiting this case better than a silica, but silica is a good constitutional remedy in this particular case. Similarly, who knew that, in a previous case, apis will come up as a, normally we in abscesses, what we do is, we usually think of, we'll give HIPAA, silica, but then now in this case we thought of apis coming up in a case of aqueous cystitis. So identifying the disease phenomena and picking up characteristic modalities are very important. You understood? If you don't pick up the modalities, you lose the valuable information for the treatment of the disease. Okay. Any other question?
Yes, sir. Yes, sir. A few more questions are there. If you permit, we can take it.
Yeah, yeah.
Okay. In third case, aortoarthritis, what happened to renal stenosis?
Renal stenosis, patient was already on long-term treatment for the renal stenosis. Here, we did not focus on renal stenosis much because we were primarily restricting ourselves to the eye diseases. Over a period of time, patient stabilized, because in renal artery stenosis, what is more important is to first halt the disease phenomena which was seen in that patient. Secondly, patient, because renal artery stenosis is that is one of the important cause of uncontrolled hypertension. So patient who was on antihypertensive drugs, we could wean off those drugs, and patient was only on single molecule of hypertensive drug. Along with that, we were giving homeopathic medicine. So patient overall settled down, and there was no further autoimmune phenomena. Because autoarthritis, the patient may develop vasculitis in any other part of the arteries, like, the peripheral arteries, limb arteries can get involved. So we had a follow-up of around 2 years of this patient. The patient eventually developed no other vasculitis. Patient's pressure was under control. Patient was initially on different molecules of the drugs, which was then reduced to a single molecule of allopathic drug. And along with that, we were giving homeopathic medicine. So I am just sharing what is realistic. There is no point in giving a lot of hope to patient, and becoming unrealistic and going into fantasy zones. So it is very important to keep our domain in the clinical zone and treat what is practical. So this is what was the outcome in the case of phosphorus of autoarthritis.
Yeah, exactly, sir. So Dr. Anudeep is asking about the rubrics for particular case, the case of keratoconjunctivitis.
Inflammation of the cornea, inflammation of the cornea, and inflammation of cornea and conjunctiva. Normally, we will not get directly vernal keratoconjunctivitis. So in keratoconjunctivitis patient, the rubric which we selected was pain stitching, pain better by cold amelioration, pain better by worse by draft of air, and stitching pain. This was the rubric, and inflammation of the cornea and the inflammation of the conjunctiva. This was the thing which we had selected. Since we are doing series of cases, if we will go in too much of detail of a single case, we will lose the entire focus of approach. We will just become, we'll have to run a workshop then. So that's why I had selected what is key things. But in this particular case of keratoconjunctivitis, where the common, what were the presenting symptoms of the patient, we had taken up that. And eye pain was in the evening. That was another thing which we had taken. So this was the totality in that case.
Okay, thank you, sir. I didn't saw any other question in the chat box right now, but So many appreciation messages are there. Everyone enjoyed this session a lot.
It's my
Thank
pleasure.
you. Yeah. Thank you so much, sir, for this session. I feel never end this session right now, but it's time is too much, and I thought it's time to you also. So we have to stop the session here. But I want to mention one thing here. What can be the best of instead of this session to conclude our webinar series? Yes, we completed the 11 days free revolutionary Homeo Vision 2020 webinar series today. And I thought this was the best session to conclude the webinar series here. The session was literally outstanding, sir. You presented very excellent cases, in especially the pathological cases in acutes actually. So where most of the homeopaths thought that the cases are not for the homeopathy. You treat them very well, and you are handling the cases and the homeopathy very nicely. I appreciate your understanding about the homeopathy, and we are heartily thankful to you for coming on our platform today and spread about so many things about the homeopathy. Uh, I thankful to all the participants who are here with us since last 11 days in the whole webinar series of our. I like to appreciate all the team members of Aisha, Dr. Arkam Mukherjee, Dr. Lavanya, Dr. Jalashri, Dr. Divyashi ma'am, Dr. Rameshwar Vishwakarma sir, Dr. Imran Khan sir, and Dr. Kinsuk Goswami sir for supporting and conducting all the webinars very nicely. On this note, we are going to conclude our webinar series today here. So thank you so much, sir, for this best presentation of yours. Thank you so much.
Yeah, my pleasure. Thanks a lot for giving this platform.
Okay, thank you, sir, and good night.
Good night. Bye bye.